Yeah. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Beauty of Motherhood, organized by TNFOG and Madhya Pradesh OG societies. So it's my privilege to introduce the convener of today's webinar, Dr. Jairani Kamraj ma'am. Ma'am is the Senior Consultant of Reproductive Medicine and also the Director of Akash Fertility Center and Hospital. Ma'am is currently the Joint Secretary of TNFOG and also Vice President of Tapisar, past President of Oxy. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. A very good evening to all the seniors, all the faculties, and all my good friends and all the Foxians here. Respected Chief Guest, Dr. Madhuri Madam, and my dear guest of honors, Dr. Rosa Madam, Dr. Vidya, Dr. Sampath, and Dr. Kavita Papat. I think she'll be joining, Madam will be joining soon. Dr. Ashta Bakshi, and my dear friend Jyoti, and all the seniors from TNFOG, my office bearers of TNFOG, and also the office bearers of Madhya Pradesh societies. I welcome you all for this webinar of the beauty of motherhood. So this month is being the Mother's Day. I thought this would be an apt one to celebrate, because it is not just, motherhood is not the destination of a childbirth, but it's an entire journey a women go through. So we should have some beautiful moments as well as some difficult moments also there in the motherhood. So we have to look this as a very emotional as well as a very happy things. All through her life, she goes through this motherhood in a special way. So to celebrate and to say things about this, not only the biological process, the emotional go through of hers and all her emotions which she go through, the lactation and the difficulties she faced through, it is really something that we should know. And we all have a lot of difficulties in such type of a situation. To see that in a better way, I thought I can see this as a beauty of motherhood. And today we have this webinar with the Tamil Nadu Federation of Obstetricians and Gynecologists group. We have 20 societies, along with the Madhya Pradesh societies. Around 14 societies are here. We are there to celebrate this beauty of motherhood. And I'm very happy and honored to welcome you, all the seniors, all the delegates here. We'll start with a Tamil Thai Valtu. We always start anything good with the prayers to our Tamil Thai. So that's a mother. Tamil mother is our motherhood. So we'll start with the Tamil Thai Valtu. Sahiti? So we'll start every academic work with, of course, the light which dispels, symbols the truth, knowledge, and also the spiritual blindness. It actually gives us a good light is always like a sunrise for the knowledge. So we start with the lighting of Kutholaka, a traditional way of Tamil. We start this with the lighting of Kutholaka. So I'm very happy and honored to welcome our dear Madhuri Madam, who is the Secretary General of FOXY from 21 to 24. And over the 16 years, she has told that her whole life is for FOXY. Madam, we are really proud to have you as the first women Secretary General of FOXY. With your empowered and dynamicity, we saw how you worked with so much passion and dedication and fully committed to FOXY. And we really proud to have you as a chief guest here, Madam. Madam is the Editor-in-Chief for Jogi 2024, Joint Secretary of FOXY from 2009, and she's the committee member of the FIGO Preterm Birth and AOF MFM Committee. Madam is the Honorary Clinical Associate of Envadia Hospital, Parade, and Mumbai Visiting Consultant to St. Elizabeth Hospitals, Mumbai. And she's the professor.
Thank you, Dr. Jayarani.
I should say all your
thank you.
I should say all your accolades, ma'am. A few at least. Madam is the DC Datta Prize for the Best FOXY Publications, Category A, and she has awarded the MOX Dr. Ganatara Charitable Medical Center Award, and she has she's everywhere in our nation all through this past 10 years. And we welcome you, Madam, to deliver your pearls of wisdom, ma'am.
Thank you, Jaya, for such a lovely introduction. I've been, in all the South, Tamil Nadu, Karnataka, Telangana, or all the Andhra, everywhere you see Kerala, my connection with them, as well as all the Madhya Pradesh, all the societies, including, Rosa is there, all the people are there, all, Katni people are there. I have very good connection with all of you. So with this, respected Dr. Vidya Prabhakaran, President TNFOG, Dr. Sampat Kumari, Secretary TNFOG, Dr. Jayarani, she's a Joint Secretary of TNFOG, and of course, convener of today's webinar, Dr. Rosa, my dear friend, Director of Olaya Hospital, and, President of Gwalior Society. Then we have Dr. Kavita Bapar, Dr. Asha Bakshi, then Dr. Madhuban, right? Madhuban, Dr. Komal, Dr. Aruna Suman. She was a joint secretary, during my tenure of Secretary General. And to Dr. Shanta Kumari. She has really worked very sincerely throughout that year. And now also she's working so much. Then, of course, we have Dr. Sumitra ji, Dr. Indu, Dr. Rohini, or Rakhi Bajpayee has not joined. She's Jabalpur Society. I had been for her installation. And for Jabalpur Society, I must say, since last 5 years, they call me for the installation. So I'm really, really lucky that way that all Madhya Pradesh and Tamil Nadu, they are my second home to me. And of course, I will not say everybody's name, but Siva Ranjani, Rarun, Dr. Sneha, very sincere and hardworking, our committee chair, and Dr. Brij Bala, Madam Revati Janki Raman, I remember, Madam, that you called me for the oration, and I was very happy to deliver that oration, and everybody appreciated. Thank you, Madam. Then Dr. Kunju Moeddin, and of course, Jyoti Banglowala, my dear friend, and of course, she's too junior to me, but she's doing excellent work. And of course, Dr. Vandana, Dr. Nidhi, my student, and Sumitra IOGSA, Sunita Wadwani, and Ratlam Society President. She is Dr. Priya, Dr. Nidhi, Archana, and all my dear friends. Very, very good evening to all of you. Let me say that it is my honor to be here addressing as a past Secretary General of FOXY to this August gathering. And Dr. Jayarani has already said that this month was the Happy Mother's Day. So this beautiful, webinar title is Beauty of Motherhood. And today we have eminent speakers and, chairperson, experts, moderator, and, panelists who are going to talk many, many things. Aruna is going to talk about preconceptional. Nowadays all the girls are getting educated. So when they get married, many of them come for the preconception counseling. And, So many things you can avoid during pregnancy. If the obesity is a now national problem, so we can tell them to reduce little bit, weight. They can do very well in during their pregnancy, intrapartum and postpartum. Then preconception, certain tests, also tell us what are they suffering, and if they are correctable, we can definitely correct. And of course, Sneha, and she's expert for that breast lactation thing. And the speaker is, I think, Dr. Aruna Suman, and the other speaker is Dr. Raja Priya, right? So Sneha is expert, and they are going to give justice to the breastfeeding and the lactation, whatever the difficulties they get, and they are excellent. And I've heard their talk, and they're excellent in that. And of course, now Dr. Revati is going to moderate about the that type of delivery, timing, type, vaginal delivery, cesarean section, decision making. Very important in today's, era, because if you give vaginal delivery and something goes wrong, patient, going to bounce back to you. Secondly, if you do cesarean, something goes wrong, they are going to do. So nowadays, we do counseling of the patient and the relative and decide. And let me tell you, that there is epidemic of cesarean section, and I have been always talking about how to reduce the cesarean section rate. And there is a what you call as environmental factor, obesity, elderly primary, multiple pregnancy because of ART. These are the environmental factor has given rise to high section rate. Secondly, non-clinical factor like fear, auspicious day, lack of staff, so you do program labor. Thirdly, of course, our clinical factor. And in that, modified factors are very, very important, where we can reduce the primary C-section rate, especially labor dystocia, induction of labor. Each and every patient, growth retarded, each and every, even they are moderate or mild growth retarded, still we take for a section, oligohydramnios. These are many patients, all breach, whether they're multi or primary, we take for section. Previous cesarean, 95% of previous section are repeat section. So these are the certain things, that is going to be very challenging, Dr. Revati. And I'm sure, everybody, all the panelists and the expert are going to give justice. With this, I really congratulate, all the organizer for the most step webinar. And I'm really happy that we have eminent speakers, chairperson, expert, moderator, panelists. They are going to give justice to these topics, and it will really help us in day-to-day practice to benefit our women's health. And Rosa always knows, and Sneha, that I will always quote Nelson Mandela, that education is the best weapon when used can change the world. So dear friend, use this education to upgrade ourselves and, change the world by just benefiting our mothers and babies. So with this, I say best luck to Aruna and Jayarani and Sneha, all of you, best luck. Along with me, I also wish best luck for myself. So thank you very much for giving me this opportunity.
Thank you, madam.
So
Thank
much,
you
madam, and best
for the
wishes to
lovely
you.
words. And thank you for your very inspirational speech, which really we look forward. And we are very sure that you will be with us when you are we really want to work with you, madam, when you are as a president. So thank you so much for your inspirational talk. And thank you.
Sure.
All the best, dear Madhuri. All the best.
Thank you, ma'am. Thank you.
Thank you, Rosa. Thank you, Rosa.
So we are now happy to welcome and introduce Dr. Rosa, madam, who is a very charming, very interesting, very encouraging, and really a lovely person. I could see in Foxy that because I've known madam more than 15 years, I used to admire her. She's just the same what I saw her 15 years back and even right now. And madam, really, your charm is really inspiration for every woman to look after ourselves in the best way, to look and to talk like you, to be a very, very nice person you are, madam. Thank you so much for joining us, madam. And it's my pleasure to welcome you. Madam is the president of Gwalior Society, and madam is the director of the Olai Hospital, Gwalior, and she's the state coordinator for the Foxy Aduna, that's the Bill Gates Foundation Project 2426. Madam is the member of the Medical Advisory Panel, Family Planning Association of India, president of the Gwalior Society presently, and madam is the chairperson for the SBC Madhya Pradesh between 24 and 25. She is the vice president of Foxy in 2014. And Madam is the chairperson of the Adolescent Health Committee, FOXY 2012. And Madam was the FIGO representative of the WHO session at the FIGO World Congress at Rome in 2012 during the special session on pre-conception care. And she is the consultant for the expert panel meet for making global guidelines on adolescent sexual reproductive health in Geneva in 2010 and 11. And she has so many awards and publications, and she has received the prestigious DC Datta Award in 2011 and awarded the prestigious Mehrodara Hanasuta Madam Prize for the FOXY Best Committee Chairperson Activities, and published over 100 peer-reviewed publications in the index journals. And she has authored 4 books and co-authored 8 books in the OBGYN.
Thank you, Jairan.
We welcome you on behalf
Thank
of
you so
TNFOG
much.
and the Federation, ma'am.
Well, thank you so much, Jairani, for introducing me in detail so beautifully. First of all, I must tell you, I admire the way you're looking today. I love that hair, that flower which is here, brings me to Chennai all the way. It's so hot here in northern India. But I must really congratulate you because it's really not very easy to make a webinar and inviting so many people, you know, from different societies. You brought absolutely not joining it with, you know, South, and having such beautiful people who are in front of me. Dr. Madhuri just talked and went. I don't see Dr. Sampat Kumari and Dr. Vidya, who are very close to me, a good friend of mine, Dr. Sampat. She's not here today, but however, I see the senior gynecologist, Dr. Revati, whom I was very closely associated with when I was a chairperson and vice president. A lot of faces here, my dear Sneha Boyer, who was also chairing a session with Breast Committee FOXY. I see dear Aruna, who has been working so hard. I see my friend, Dr. Sunita, the chair secretary of Indore, and I don't see my dear Jyoti Banglowala here. She's one of the stalwarts in Indore right now, doing extremely well as a chairperson of medical. Oh, yeah, here you come. I bring your name and your name.
I am here only, madam. I was just lost.
I was trying to see you. So she's doing excellent work in law and medical legal, one of the best we have in India right now. And of course, Vidya, I'm seeing you here, and a lot of others whose windows are closed. Well, let me tell you that the topic you've taken, my dear, is such a wonderful topic. It talks about prenatal, natal, and postnatal. And Dr. Madhuri just now explained so beautifully how they are interrelated. You know, when we had Dr. Our president, Jaydeep Tang came to Gwalior for the inauguration of the Bill Gates Foundation in Gwalior. What, the press people were asking him a question. Why there is more of C-section as compared to normal delivery? You know, the question that he replied was amazing. He said, first of all, why do you say normal? That means C-section is abnormal. So the journalist took aback, saying, oh, no, we don't mean to say it's abnormal. So he said, then you should change what you're saying. You should say vaginal delivery versus C-section. And there are, points which go in favor of a normal delivery. There are certain things that doesn't. So it goes for a C-section. So please change. And it came in the newspapers everywhere that there's nothing like normal and abnormal. So little, we have to change what we say. And I'm so happy you're talking about normal deliveries here. Now, as far as your elections are concerned, Rani, I know you're going for an election. Wish you all the very best. Keep up going ahead. Do your good work. You see, a good work pays in the long run, and people do recognize. Recognition is important as per what, as a human being, one is. The way your relationship is with others beside the good work you're doing. So wish you all the very best. I see even Aruna and Sneha going for, I call you Snehata all the time. Sneha going for elections. So all of you will go ahead, have a wonderful time. We had our time as chairpersons and vice president. We've tasted it. Well, let me tell you, whether you are in a position or you're not in a position, you can always serve society. And that is what we want. Service is equal to happiness. Well, if you have a position, you may have a little bit of hands to work with. However, you can always work in any circumstances because there's no end to good service. So I would like to congratulate everyone, the people who are in the organizing. You've got a very good team. Rest of the people are all into windows, and I can't just say anybody. Wish you all the best. And please go on with your program, because people come on time and they want to know, they want to listen to scientific session. Go ahead. All the very best to all of you.
Thank you, ma'am. Thank you so much for your kind inspiration and encouragement. Definitely, as you rightly said, that working for the committee or the community, that matters. It's not the position. It is all how we are committed to the society that's important. And we really take your words as our way to work for the committee and the community with all your blessings, ma'am. Thank you so much, ma'am. Thank you for being with us and giving us a good inspiration, ma'am. Thank you, ma'am. And now,
always a pleasure.
It's a pleasure, ma'am. Let me have the pleasure to welcome and introduce Dr. Kavita, madam. Madam will join after some time, but I will introduce her formally. And Asha, madam, has also said that she'll join a little late because they're held up in an emergency. And Kavita, madam, is the Vice President of FOXI 2021-22, and she's the Director of the Bapat Hospital Indore. And she's very famous for the one-day hysterectomy. And she's a Jogi peer reviewer. And she has done a lot of ICOG vaginal surgery certificate course. And she's the president of the Indore Menopause Society and the vice president of AMPOG. And she's the executive member of the ESAR and the IAGE and the past governing council member of ICOG. And she was the chairperson of the breast committee FOXI 2016 and 2018. Madam will be joining little late, but I'm happy to have her, and thank you for accepting her invite. And Asha, she just called up. She's held up in an emergency, so she will join up a little later. She's a good friend of mine who is the lead consultant of Asha Bakshi Fertility Center in association with the Motherhood Hospital Indore. And she's the vice president of FOXI West Zone in 2022 and treasurer of ESAR. Right now, she is the secretary general of the ESAR. And member of the executive committee of ACOG RCOG West Zone, and founder chairperson of the Madhya Pradesh IAG and the Madhya Pradesh ESAR, and chairperson of the FOXI Infertility Committee between 2017 and 2019, member of the ICOG Governing Council between 18 and 21, and the past president of the Indore OBGYN Society. And she has done a lot of credit in the IVF as in the ART specialist and delivered so many ICSI babies and TISA babies, organizing chairperson for the ACOG 2022 Indore. We welcome Asha madam, and she'll be joining with us to give us a few words of wisdom. And I have the great pleasure and honor to welcome our federation president, the dynamic young Vidya Prabhakar. Madam is the president of the TNFOG 25-26. She is the past president of OBGYN Society of Salem, and she has got her ART training from Singapore, and she's a senior IVF consultant in Salem, and she has been the Tamil Nadu coordinator for preventive oncology committee between 22-24, and she's the recipient of the FOXI Dira Award and the speaker in the national and the state forums, and organized very many conferences in the national level. The one among few is the FOXI South Zone Conference, Zonal Conference, UR 22-22. And also she is a certified instructor by the American Association of Family Physicians. And she has a special interest in high-risk pregnancy and infertility. And all the more, she has a very good capacity of organizing very nice events with a good friendliness and friendship with everyone. Over to you, Vidya, for your kind words.
Thank you so much, Dr. Jairani. I think that was a very beautiful thing you said at the end. So organizing conferences with the friendliness, I think I would appreciate that more than anything else, because when we organize, we get to meet so many people, and I think it is a friendship that we get through these conferences. That is what I like, and that is what eggs me on. And so in front of so many, stellar star cast today, I find that from Madhya Pradesh, we have so many illustrious persons. Now, Dr. Madhuri Patel ma'am is always very close to my heart. So apart from being, all those things that you mentioned, all her achievements and then her illuminated, illustrious career, and I'm sure she's going to become the FOXI president also, and then going to guide us and all. But apart from all that, she's a very good human being. And what I've seen is she is very down to earth and very good human being. I wish her all the best, ma'am. And Dr. Rosa, she comes across as such a charming and, the well-established consultant, and with so many other attributes. She seems like, a woman of substance, actually, and she comes across like that. So she's many faceted. So I'm happy to be around with her. And I salute Dr. Revati Janakiraman, ma'am. She has been here. She's such a sincere person. And apart from being very senior, she's very, very sincere. And whatever topic she takes, and I've always seen whatever topic you give her, she does full justice to that. I'm sure we are all waiting for what she's going to say in that panel today. And Dr. Sneha Bhuar, ma'am. So she is also running for the elections and has had a wonderful career so far. And I wish her all success in future. And all the others. And Dr. Aruna Suman. Yes, Dr. Aruna Suman. Again, another person whom I've seen in any kind of situation, even troublesome situation, anything, she'll be always smiling face. One person you can look at and smile, you can forget all your worries. So Dr. Aruna Suman, ma'am, and I wish you all success too. And so many other people are here. Dr. Kavita Bapat has not yet joined, I think. And for all the people who are here, I think I'm forgetting to mention a few names. Please do forgive me. I'm extremely happy to be here, extremely honored to be here with all of you. And the topic Dr. Jairani has chosen today is so beautiful in the sense that we all keep on thinking about troubles. We are always thinking about, a problem pregnancy, troublesome pregnancy. But she has brought out the beauty of this journey. So I think sometimes we also need to look at, how to take care of a normal lady and keep her normal that way. So many things you can do right to keep that journey safe. So if you recognize the problems right in the beginning and then take her the right way, so the whole journey will be beautiful. And then there is also this topic of Dr. Sneha Bhuar, who was very close to the lactation part. So a normal pregnancy and a normal postpartum period, it should remain always normal. So for this beautiful journey, I think Dr. Jairani Kamraj has chosen a very beautiful topic today. And I wish you all success to Dr. Jairani for your upcoming elections. And thank you very much for having me here. I'm honored to be here. And over to the next.
Thank you, Vidya. Thank you for your very emotional and very friendly talk, and all the wishes that you have showered on us. Hopefully that everybody will be succeeding with all your wishes. Thank you so much, Vidya, for joining us.
Thank you.
So without wasting time, we'll move on to the next session. I have the great pleasure and honor to welcome and introduce Dr. Sampath. I think Sampath will be joining. She has another program, and you all know her. She doesn't need any introduction. She's such a dynamic person who works for Oxy, and all her federation is because of Sampath. So we'll move on to the academics, and I have the great pleasure and honor to welcome my dear friend Dr. Madhubala Manikavasagam. She's from Tirunelveli. She's the present president of Tirunelveli OB/GYN Society. And she's an alumni of Stanley Medical College, and she's a national gold medalist in Dipendhi in 2000, and practicing in Tirunelveli at Lakshmi Madhavan Hospital. She has presented many national and international conferences, and she's very much interested in lab surgeries, very much in the gynec and the hernia repairs, and practices high risk in obstetrics and infertility. Over to you, Dr. Madhupala, for chairing the first session. And I'm greatly honored to welcome Dr. Komal Jain, who is the secretary of the Jabalpur Obstetric and Gynec Society, very young and dynamic, with so much dedicated work in the gynec field. We welcome you, Dr. Komal. So I hand over the session to the chairpersons. Is Dr. Komal is here? Madhubala is here? I think she said that she joined a little late, but at 7:30. Okay, I have the great pleasure and honor to introduce my good friend, Dr. Aruna Suman, who don't need any introduction, very dynamic person, always with cheers, will smile. And as rightly pointed out by Vidya, whatever the situation, she's always keeping on smiling. That's a very important aspect that she as an OB/GYN should have. Because whatever the difficulties, we should not show up except with a smile. And I'm really happy to welcome you.
Thank you, Dr. Jairani.
And she's the Joint Secretary of the FOXY 21 and ASUOG 24 Organizing Secretary, Professor of OB/GYN HOD of the Medical College, Jagital in Telangana. She's the Practice Obstetric Committee FOXI member 24-25, a national coordinator for the No to Violence Against Women Committee, the South Zone coordinator of FOXI in 22 and 23, Adolescent Health Committee member of FOXI in 2016 and 18, Vice President of Obstetric Gynecology Society of Hyderabad 2020.
Thank you, Dr. Jairani.
Over to you, Aruna, to speak about the topic, the pre-conceptional care, how to have safe motherhood. Let me hand over to you.
Let me share my presentation. Thank you for this great opportunity, Dr. Jairani. And thank you so much for always believing in me and giving opportunity in every webinar of yours. And it's my privilege and honor to share this digital platform with all the seniors, Madhuri Patel ma'am, and our Revati Janaki Ram, who is very friendly, and she's a genius, I should say, and Rosa Ole madam, Dr. Sneha Buyar, Dr. Jyoti Banglawala, Dr. Vidya Prabhakar. I have been working with them as Joint Secretary. Thank you so much for this great opportunity. And you have chosen a very good topic. Congratulations for that. And my topic for today is prenatal care to ensure safe motherhood. The primary objectives of prenatal care is to identify high-risk pregnancies and to monitor the health of the mother and the development of the fetus for good outcome. Prenatal visits, that is antenatal checkups, are an intricate balance of maternal and fetal management aimed to prevent significant maternal and fetal morbidity and mortality and provide support throughout the prenatal course. Why do we need to have a good prenatal care? It reduces the risk of pregnancy complications. Regular prenatal care helps identify and address potential problems early and reducing the risk of complications for both mother and baby, improves maternal and fetal health. Prenatal care ensures that the mother receives the necessary medical attention and support to maintain her health and promote healthy fetal development. Reduces the risk of low birth weight and infant death. Women who receive prenatal care are less likely to experience low birth weight infants and sudden infant deaths. Increases the likelihood of full-term delivery, yes, with good care. Early and regular prenatal care can help women reach full term, ensuring that their baby has the necessary time to develop in the womb healthily. It consists of preconceptional care, but this care is lacking in India. Not many women come to us before conception, but definitely it's a good opportunity if we meet the woman during her preconceptional care. The advice we give will definitely help her throughout her pregnancy and have a positive birth experience. Prompt diagnosis of pregnancy, initial presentation for pregnancy care is important, follow-up of the prenatal care. Risk stratification. So whenever she comes to us, we have to stratify the risk. That is, does the pregnant woman belong to the low risk, high risk, or medium risk? Accordingly, we have to give the care. These may include escalation of care to more frequent antepartum care visits, close follow-up by maternal fetal medicine specialists if necessary, antepartum fetal surveillance in high-risk cases, potential early delivery depending on the gestational age and according to the situation or the medical morbidities, the clinical picture she is presenting, and potential improvement of the outcomes will be there definitely in this situation. So we should take a proper social history. So maternal age, teenage pregnancies will definitely have complications. We'll have to educate the women, the parents, the society regarding the community health to prevent the teenage pregnancies, which will have more of complications. Advanced maternal age. Nowadays, we are seeing many women coming with late pregnancies when they are above 30 or 35. They will definitely have the NCDs that we cannot prevent and they'll land up in complications. So we have to definitely educate them regarding the correct age of conception without any medical complications. And smoking, alcohol, recreational drugs should be avoided. We have to educate them. Domestic abuse. This is an important aspect in women's life. Inquire about the risk factors regarding the domestic abuse, and we have to take a proper history. Diet, is she a vegetarian, vegan diet? Definitely, we have to consider that. And obesity, we all know there can be many complications if she is obese. So optimizing the health of the woman before conception is very, very important. Exercise. She should continue her exercise during her early pregnancy too, with prenatal exercises and yoga. Environmental exposures and toxins. Infections are common. The chemicals, industrial waste, the pesticides, women living in rural areas, mercury which is present in large fishes, cosmetics that we use, our lipsticks, our creams, definitely will have the toxins which are endocrine disruptors. The cookware we use, the Teflon coated ones are definitely, they're going to have a negative effect. The perfumes and the plastics. The plastics, recently they have done a study. There were plastics found in the placenta and the fetal brain. That is very, very dangerous. We have to avoid those. What are the aims of good prenatal care? Identify the components of the initial prenatal care visit. Implement recommended screening tests during the initial antepartum visit. Differentiate low-risk pregnancies from high-risk pregnancies. Apply interprofessional team strategies to improve antepartum care coordination and the patient outcomes. Screening tests. Yes, prenatal care includes various tests and screening to assess the mother's health and detect potential complications or conditions such as gestational diabetes, preeclampsia, infections, and anemia. So, education and counseling are very, very important. Pregnancy education, also known as prenatal education, is a comprehensive approach to prepare expectant parents for the journey of pregnancy and childbirth and early parenthood. It equips individuals with the knowledge, skills, and resources needed to navigate this transformative period successfully. So, we need to provide the respectful maternity care at all stages. Prenatal care provides information and guidance on various aspects of pregnancy, including nutrition, exercise, childbirth preparation, and baby care. So we have to educate regarding the prenatal care, regular checkups, the importance of maintaining good nutrition, health, everything, and physical activity. Labor and delivery preparation should be there for her to have a positive birth experience, childbirth education to overcome the tocophobia. There is something called tocophobia. She has the fear of uterine action. She thinks it's very having a normal delivery or a vaginal delivery can be very, very painful, and she doesn't want to have a normal delivery, vaginal delivery, I mean to say, and she prefers only cesarean section. So the childbirth education with all the pictures is very, very important, putting them in our clinics. Newborn care, parenting and childhood development in the early neonatal period and growing, regarding the vaccinations, nutrition,
Sarna, you lost.
She is trying to join again. She got disconnected, it seems.
Yeah, she's lost, madam. Her connection is lost. I'll call her. Madam, I think she's not answering.
You are not able to get her.
Yeah, we cannot get her. Can we move on to the next talk?
That will be better. We can save
Rajpriya
time.
is here.
I didn't see her. Rajapriya? No. Sahiti, did you see Rajapriya joining?
Actually, ma'am joined at 7:05 something like that, and after that I cannot see her, ma'am.
Maybe.
I'll call her, ma'am. I'll call her. Priya here, I'll call her.
Aruna ma'am has joined back.
Madam basics
I lost my connection. Can I continue?
You got it? You got the net connection?
Yes.
Okay,
Can I
continue. I just called up. Rajapriya also had some issues. She's also joining. You can carry on, Aruna.
Okay. Right. Thank you. Okay. So sorry for the inconvenience. I lost connection in between. So screening tests during pregnancy are designed to identify potential risks and health issues for both mother and child. These tests can help detect the conditions like genetic disorders. Am I audible? Infection, health problems, allowing the timely prevention and management. Yeah.
Make it as a full screen.
Yeah, okay.
It's in the slideshow.
Yes.
Make it as a full screen.
Okay, right.
Yeah. That was okay.
So recommended components of the initial prenatal care visits, according to the ACOG or WHO is also accepting this risk assessment to include genetic, medical, obstetric, and psychosocial factors, confirmation of pregnancy, estimated due date, general physical examination, laboratory tests, but whatever we do regularly, and HbA1c test if it is indicated, or routinely sometimes in some areas, in endemic areas where the hemolytic disease is common. And I would like to insist on one thing: doing 2D echo and ECG in the first visit is very, very important. In Telangana, recently we had a maternal mortality audit, and most of the deaths were because of the heart disease that is missed. Sometimes definitely we miss auscultating the heart when she comes to us in the first visit. So auscultating the heart, ECG and 2D echo is very, very important. Ultrasound examinations are essential for accurate gestational dating, detectable multiple pregnancies, screening for congenital anomalies. It is done early dating scan, early TIFA at 11 to 13 weeks, TIFA scan at 18 to 20 weeks. This is a skeletal survey. Again at 32, 34 weeks for the growth. If the serial growth scans are necessary, if we are suspecting growth restriction, yes, definitely we have to do more ultrasound scans. Prenatal genetic screening for conditions like aneuploidies and carrier screenings for genetic disorders are also offered in the first trimester. Prenatal screening and genetic diagnostic testing for genetic disorders at the first visits can be offered, but not routinely in India. I work for a public sector hospital. We don't offer this because we don't have the facilities and we don't have the fetal medicine specialist. Thorough counseling on available genetic screening and diagnostic tests are options like cell-free DNA, serum integrated screening, nuchal translucency screening, chorionic villus sampling can be done depending on the gestational age to ensure that patients are able to make informed decisions regarding the prenatal genetic test screening, evaluates the risk of the fetus having a specific genetic disorders. So these are the many screening tests that we can offer: the combined test, quadruple test, integrated test for various diseases. Yes, taking a proper history is very, very important. So we have to spend more time, and availability of the senior consultant or a senior obstetrician is very, very important to make a decision in our OP. 1 in 4 pregnant women have significant identifiable treatable complication. So that has to be diagnosed earlier and managed properly. Major categories for increased risk are pre-existing medical illness, previous poor pregnancy outcome like perinatal mortality, preterm delivery, FGR, malformations, placental accidents, and maternal hemorrhage. Evidence of maternal undernutrition and deficiencies can be diagnosed and guide her in a proper way. Detailed information concerning past obstetric history is crucial because most prior pregnancy complications tend to recur in subsequent pregnancies. Psychosocial issues like cigarette smoking, alcohol, drugs, and domestic violence, and taking coffee daily 2 cups is sufficient, and other drugs should be taken, and it should be changed whichever is safe during pregnancy. Suppose she's on antihypertensives or anti-diabetic drugs which are safer during pregnancy, it can be shifted for the safety of the mother. Pregnancy is a window of opportunity. Pre-existing hypertensive disorders like chronic hypertension may only be discovered during the prenatal evaluation, as this is the only encounter a young female has had with a health professional. So she will come to us for the first time during her early pregnancy after missing her period. Then only we'll come to know after checking her blood pressure that she's a known hypertensive, not on drugs. So this is the correct method of checking her blood pressure. I'm not going to go into the detail of that. Obesity, yes, this is another risk factor. So optimizing the weight of the woman is very, very important. The complications are more. Screening for the diabetes, yes, according to Government of India guidelines, DIPSI testing, which is a single step screening, and this is done at first visit, 24 to 28 weeks, 32 to 34 weeks. Identify the gestational diabetes early and manage her properly. Both maternal and fetal surveillance can be done. So physical examination should be meticulous from top to bottom, and the obstetric examination of the breast, and we have to listen to her complaints and pay attention to whatever she says, even including the small issues or small symptoms. So we all know how to examine an obstetric woman with all the grips, to know the presentation, to know how her fetus is lying inside clinically. Subsequent prenatal visits. According to WHO, minimum antenatal visits are now 8. Initially, it used to be 4. To prevent the neonatal morbidity and mortality, the visits have been increased to 8. 13 to 14 visits are ideal if she's a high-risk woman. And we all know at what intervals we have to see. At each visit, steps are taken to determine the well-being of both mother and fetus. At every visit, we have to do a hemoglobin. First, initially, we have to do a CBP to know her level, how she's presenting. We can calculate the Menzer's index. We can see other parameters, but whenever subsequently she is coming to you for every visit, we can do hemoglobin testing. So these are all the maternal surveillance, how we are going to do. Vaccinations in pregnancy, yes, according to Government of India guidelines, we are giving TT that is available for us in government hospitals, but 3-in-1 vaccine, that is known as Tdap, is best, which can prevent the pertussis, diphtheria, and tetanus toxoid in the neonate till he receives the vaccinations. So in high-risk patients, we have to do the antepartum fetal surveillance. The primary goal is to prevent the stillbirth, detect it early, and we have to deliver the woman before the baby succumbs inside the womb. The antepartum fetal surveillance is started as 32 weeks. It can be started earlier if it is necessary. If your center can survive the baby of less than that, I mean even the 7th month, if it is 500 grams or 600 grams, something like that. So what are the antepartum fetal surveillance consists of? So fetal kick count, non-stress test, and biophysical profile, umbilical artery Doppler velocitometry, only if there is a proper indication. It's not necessary in a routine antenatal woman. So we all know who benefits from the antenatal fetal surveillance. Alert signs during pregnancy. So we have to alert the woman regarding the danger signals. like vaginal bleeding at any gestational age, severe headache with blurred vision, fever, severe abdominal pain, reduced fetal movements. Many women come. In my setup, I have seen at least 5 women having stillbirth, because after doing fetal surveillance, everything was normal. They go home and come back with stillbirth. That's very, very dangerous. We have to be very careful. If she's throwing convulsions and fits, yes, definitely, these are the danger signs. Swelling. Almost 40% of the pregnant women can have edema. But if there is a pathological edema, it is significant. Dizziness or fainting, shortness of breath or difficulty in breathing, chest pain, nausea and vomiting, fatigue are some of the danger signs. So the weight gain during pregnancy is almost 11 kgs if she is normal. If she is overweight, she can have 7 to 11 kgs. If she is underweight, the woman can aim to have almost 12 to 18 kgs during her pregnancy. So we have to educate her regarding the nutritional requirements. Energy, 350 calories per day is recommended, and from the second trimester onwards, protein intake, micronutrients, iron. Prophylactically, we have to start from 14 weeks. Calcium, iodine, and vitamin A should be given. Iron supplementation should be started from 14 weeks. 30 to 60 milligrams of elemental iron is given. 400 micrograms of folic acid supplementation, and iron should be almost continuously given up to 6 months to replenish the stores. And definitely, if she is not tolerating the oral iron, or she is not able to accept, or there are any other reasons, definitely we can give her intravenous iron preparations like ferric carboxy maltose or iron sucrose. And prenatal vitamin supplementation, yes, definitely. If there is an indication, we can use multivitamin also. These are the recommended daily dietary allowances according to the National Research Council recommendations. I'm not going to go into the detail of that. So prenatal care for safe motherhood definitely will help with peri-conceptional counseling, good antenatal care, proper risk stratification, early diagnosis and management by the experts. The senior obstetrician should be definitely involved. Education and motivation of the woman and the family, and involving the family regarding this safe motherhood is very, very important. And interprofessional team involvement is definitely good, and it will give a good, better outcome of the mother and the child. So prenatal care for safe motherhood is good, and the essentials should be followed by us. Thank you so much. And I appeal, please nominate me and vote for me for Chairperson, International Academic Exchange Committee. Thank you so much.
Thank you, Aruna. Thank you so much. Thank you for the very comprehensive and well said prenatal care, which is always forms the basic for any good, safe motherhood. So definitely the preconceptional care of any women will lay the path for a safe motherhood. Thank you so much for giving all the insights about it. Thank you so much. We'll move on to the next session. I have the great pleasure and honor to welcome Professor Madam Dr. Sumitra Yadav, who is the president of the Indoor OBGYN Society, and very dynamic very dynamic person, looking young in heart and mind, and very, very active person. I really love her. We welcome you, Madam Sumitra, Madam, to be the chairperson of the second session. And we have the great honor to welcome Dr. Rakhi Bajpai, who is a life member of IAG and the president of JOGS 2526. Madam has awarded the felicitation by the Madhya Pradesh government, providing services in National Pradhan Mantri Sukrita Matriya Abhinaya Award, and she has got the Bharat Excellence Award, and she has got a biography in Asian American Who's and Who, and she has publication in the Asian Journal of OBGYN and IMA Journal, and she has created a lot of awareness program in the rural medical camp, free medical camp, very many blood donation camps, and environmental friendly camps. And she has done a lot of tree plantation camps with the society. Welcome you, madam, for all your very passionate work on the environment. And I have the great pleasure and honor to welcome Dr. Sivaranjani Arun, who is the postdoctoral fellowship in reproductive medicine, has done an advanced fellowship in infertility from NUH Singapore, and she has done a master's in reproductive medicine from Homerton, London. And she's a cosmetic gynecological fellow from the American Aesthetic Association. She's the gold medalist and best outgoing student award, and has achieved a lot of good awards in a younger age, like the Young Achiever Award by the Indian Society of Assisted Reproduction in 2024, Young Achievers Award by the IMA. We welcome you, chairpersons, for the second session. Over to you to introduce the speaker and the expert. Sumitra madam is there? Swaranjani, I think you can introduce the expert and the speakers.
Good evening, everyone. It's my pleasure to be among all professors and accomplished gynecologists in the country. I take great pleasure in introducing Madam Sneha Surendra Huyar. Madam is a managing director from Sukarta Hospital. Madam has 32 years of experience in the field, teaching experience in SVN Government Medical College. Madam is our candidate for Vice President Foxy West Zone in our coming elections. Madam has various awards to her credit. She's been an organizing chairperson in many conferences from 2018 Criticare to BreastCon in Pune 2020. Madam has held a lot of official posts as chairperson Breast Committee Foxy, Governing Council member ICOG 2021-22, chairperson Medical Disorders Committee AMOX 2022-24, founder president of Vidarbha ISOPAB 2017-19, President Yorks 2007-2008, founder Clinical Secretary Yorks 2003, and Executive Committee member AMOX 2020-2022. Madam holds a lot of papers to her credit in research and is an avid person who gives talks and publications. More than 25 articles or chapters have been published in national she's got national publications to her credit, and more than 300 talks in state, national, and international conferences. Ma'am, it's a pleasure to invite you for this webinar and waiting to hear you, ma'am. Over to you.
Thank you so much, Lord. Thank you so much. Is Madam Sunita Madam is here? Suranjani, can you introduce the speaker, Rajapriya?
Of course, ma'am. It is my great pleasure to introduce Dr. Rajapriya Ayappan, Madam. Madam is a managing director of Home Fertility Center, Srinivas Priya Hospital, Chennai. Madam holds 2025. Madam is the past secretary and patron of Indian Fertility Society and Sexual Health Committee member, Foxy, joint treasurer of ATNR COG, and Madam has been the examiner for MRCOG Part 3. Madam needs no introduction for people in South India. She is a part of all the conferences. Her talks are very interesting.
So
She makes sure that she holds the crowd. It's a pleasure, Madam.
Thank you so much. And I thank Jairani ma'am. It's actually a very interesting thought to be able to bring in the beauty of motherhood. And a lot of beautiful people are out there today. So I hope this novel attempt would bring in thoughts together. And I wish all the people taking part in the elections, because so much of time and effort and commitment and devotion. And I wish all the best to all of you out there contesting. And without further delay, let me get back to my topic. Lactation benefits, difficulties, and techniques to overcome. Now, breastfeeding is a very unique opportunity of connection between mother and baby. It's a bond forever. And how best we as obstetricians, we help them to achieve their maximum potential is what we're going to talk about in the next 20 minutes. WHO gives a clear message that exclusive breastfeeding is important, at least from the time of birth to 6 months of age. And for those who can, going up to 2 years is definitely great to meet the nutritional needs. And one of the most important things today which we practice is no pre-lacteals. So at birth, we don't allow that sugar water or anything to go. And with a lot of effort, primarily from the obstetrician and more energetic pediatricians, as high as 60% is initiation of lactation in Tamil Nadu.
And Tamil Nadu is actually doing a great deal of effort even in maintaining breastfeeding for 6 months. The rest of the country, overall in India, if you see, initiating feeding within 1 hour is 41.8%, and exclusive breastfeeding is around 63.7%. Keeping that in mind, let's just let quick revision of the physiology, how breastfeeding per se works. We have suckling as the key stimulus from the baby, which gives in the sensory input to the hypothalamus, which acts on both the posterior and the anterior pituitary, giving rise to oxytocin and prolactin hormone. So the prolactin hormone initiates milk production, and oxytocin is important for milk ejection. So on the whole, a lot of activity is happening on the glandular epithelium and in the myoepithelial cells. And a lot is finally acting on the brain and the mindset of the woman and how the baby latches. So with this keeping in mind, we can help the woman to establish a good lactation practice. Now, how much of milk is produced? Round about 1.2 liters of milk is produced in the first month. And from the second month onwards, around an average of 2 liters per day is the milk production. And this is able to meet the initial energy requirements of the baby of around 500 to 600 kilocalories. So the key to establish maternal confidence and bonding with the baby and deterrence which happen in lactation establishment is anxiety, stress, worry, and insecurity in handling the baby on the part of the mother. Now, if you take per se of the woman, how much of additional calorie need she would need? During lactation, she needs an additional 550 calories per day. She needs good rest, good hydration of 2 to 3 liters, quality sleep. It may not even be night sleep, but at least good quality sleep of around 6 to 8 hours, avoiding certain habits like alcohol, smoking, wearing comfortable clothing, and ensuring the privacy and comfort to feed. Like basically the environment should be supportive for her. And today we have maternity clothing, clothing to suit breastfeeding, feeding bra, etc. Fundamentally, what are the advantages of breastfeeding? For the mother, it protects her from obesity, helps her to get into a better shape and care because of more metabolic burning happening. And by establishing bonding, she can overcome postpartum depression because the whole thing happens about her emotions towards the baby. So it helps in better bonding, less depression and mental health issues. And of course, long-term protection is from breast and ovarian cancer. So overall for the baby, if you see, for the baby, it's for better brain development, more immunity, so less ear infection and less respiratory infection and less GI infection. So the diarrhea aspect and all that, we can protect the baby. For the baby per se, it's clearer vision, jaw alignment, and over a period of time, soft and supple skin. Now, what are the different types of breast milk which happens? Initially, for the first few days from the time of birth, the milk is termed as colostrum. Subsequent 4 to 14 days, it's the transition milk. Then once regular lactation happens, it's partly fore milk, and the later part of the feeding, the hind milk comes. Based on it, the color of the and the texture of the milk differs, and the richness, whether it is rich in antibodies or whether it's rich in vitamins and lactose and proteins, and the hind milk is richer in fats and sugars. So what does this ensure? Colostrum ensures immunity to the baby. The transitional milk pattern will ensure that the quality of the milk gets a little bit different, and the fore milk ensures, because it's more watery, it ensures that the thirst of the baby is satisfied and it hydrates the baby. Whereas the hind milk, which is richer in the fats and sugars, gives satiety and energy to the baby. So it is important for us to understand the nature of the milk and help the woman to get into the right position to feed the baby. What would be the right position? How she is supporting the head of the baby, how she is supporting the whole body of the baby. And is there an eye-to-eye alignment from the mother's eyes to the baby's eyes? Is her head and neck properly held? All this is important. When the eye contact is not made, when the baby is loosely held, and the bad posture problem happens. The held straight head and the back posture is pretty important to be able to give the alignment, and not curving, because this would give long-term neck pain and back issues, and proper positioning of the mother and baby is key for successful lactation. So this is something we have to educate them. And depending upon the situation, a cross cradle or a lying down or a cradle hold or a side lying football hold positions are all available. So it's what suits the mother and the baby. The key is how the mother holds herself and how the baby is supported. This is the key for lactation. Some women soon after cesarean actually prefer lying on the side lying position. As they get up and move, they would like to go on to different other positions. Let's come to latching. Now, latching is the most important for long-term lactation. So suckling should be comfortable and pain-free for the mother, so she regularly gets into the habit of breastfeeding. Similarly, for the baby, once it's latched well and had a good feed, it would look contented and relaxed, and it would release the breast on its own, like it would stop suckling on its own. And at the end of the feed, the woman also feels her breasts are getting softer. And if latching has not happened right, like how you see in these pictures, the woman needs to understand that during lactation, it is not that the nipple feeding happens, it's actually the areola which goes into the mouth of the baby to be able to effectively get a good suckling effect, for which the nose, the lips of the baby and the chin of the baby should be watched. The nose should be free and the chin should be immersed into the breast tissue. So once the woman understands that most of the areola gets into the mouth of the baby for effective latching, then things will fall in place. Now, there are certain conditions where a flat or an inverted nipple will happen. A true inverted nipple is actually very rare, but a flat nipple would be identified, and by a pinch test, if it protrudes, then it is not a true inverted nipple. This can be graded depending upon how the pinch test would allow the nipple to come to get into a protrusion mode. This is something we have to evaluate. And if it is looking like a absolutely inverted nipple, then this picture illustrates how we can take in a syringe, cut off the syringe, the needle end, bring the piston to the other side, and ensure that the nipple doesn't get injured, and through a suction effect, you can pull out the nipple. Manual pinching out is also possible, or using a plastic syringe is also possible. Now, what if the problem of proper latching doesn't happen? Over a period of time, there is pain and damage to the nipples where nipple fissures occur and it feels sore for the woman, because of which breast milk is not effectively emptied, which would lead to breast engorgement with milk, and the baby is unsatisfied. Over a period of time, the baby gets frustrated because proper milk supply is not going to happen. The breasts produce less milk because the emptying is not happening properly. Baby, because it's not suckling well, fails to gain weight. So keeping this in mind, latching and keeping that area clean, and not pull the baby away. As the baby is suckling, if you're going to pull the baby away, it would lead to injury of the nipple and lead to nipple fissure. So the treatment is proper positioning and latching, ensuring local hygiene, and allowing the breast to breathe. You can't keep the breast milk soaked. We have to make sure we're keeping it clean, and also applying some emollient creams like lanolin. Now, if this is not happening, breast engorgement would happen, particularly in delayed or infrequent feeding, and you would find that the breast is swollen, hard, warm, and painful. So it is important for us to identify it early and treat it. Treating it in the support, give breast support, use warm water packs like a duck back pack, and gentle massage, and help the breasts from the base towards the nipple, so the breast starts getting emptied, and using analgesics. This would help the breast to soften. Now, when you're getting confused, is the breast full or is the breast engorged? Simple thing is, a full breast usually occurs soon after birth, within 36 to 72 hours. That is even before the woman may get discharged from the hospital, because she's not yet understood how to latch, how to position, and how to help the baby feed. Here, the breast will be hot and heavy, but the milk will be flowing, and fever is uncommon. Engorged breast is a situation which can occur at any time when faulty breastfeeding habits happen, where the breasts are painful, edematous, they may look shiny, the milk will not flow out, and sometimes they may even develop fever. So it is important for us to understand that a full breast is part of the transition of how the mother is learning to feed the baby, whereas engorged breasts need to be attended. If they are not attended, then comes mastitis and breast abscess, etc. Again, this is a good illustration where the woman will come to understand that within the baby's oral cavity, there's a hard palate, soft palate, and a tongue. And the nipple and areola has to go well into the baby's mouth, so that during suckling, the nipple is squeezed between two soft tissues, that is the tongue and the soft palate. If that doesn't happen, if the hard palate starts hitting on the nipple over a period of time, then comes the soreness of the nipples. We have to ensure that the nipple is caught between soft tissues of the baby's oral cavity, the tongue and the soft palate as seen in this picture. Now, there are certain tricks. Sometimes the woman is very large. She will be around a 110 kg and the baby will be just a 2.5 kg baby. We need to again understand how she directs her arm, especially her fingers, such that the nipple and areola can be either in a C hold position or in a U hold position or even in a scissoring pattern. So she feeds her nipple and area into the baby's mouth and thereby effective emptying of the breast milk can happen. So these are some latching tricks women need to be taught. Now, what are the other cues? Sometimes the woman keeps on breastfeeding because of which her nipple can be sore. She needs to understand the baby needs to be fed on demand. How will she understand that the baby is ready for a feed? So the baby can give certain cues which she would learn over a period of time. What is the baby's language, the body language or the way the baby cries, that this is meant for breastfeeding. So these are simple watching the baby, communicating with the baby and observing the baby where she will learn the baby's cues and be ready to feed the baby on demand. Now, mastitis is a condition where the drainage of milk is important. If the milk is not emptied well, the stasis milk would get infected and abscess tends to occur. So ideally to prevent breast engorgement is key to prevent mastitis. But once mastitis has occurred, the woman can continue feeding, but she may need hot or cold compress, whichever relieves her pain. Use analgesics and antibiotics if necessary. And a gentle massage from outer towards the nipple will help her to come out of mastitis. So in this particular picture, usually a duct block would lead to a mastitis, which may be local or diffuse. And let's look into special situations where the woman can have problems in breastfeeding. See, soon after C-section, as it is the cesarean scar area, she may feel pain and mobility may become a problem if she's on regional anesthesia. So she would depend a lot on the healthcare staff to initiate breastfeeding soon after delivery. And health professionals should take the opportunity to put the baby to the breast within 1 hour of delivery at the earliest possible moment and to a position that is comfortable to the baby and the mother. So she needs assistance of health professionals. Now, what about twins? Again, in twins, good support and encouragement to the mother will help her to successfully feed both the babies. It's just a matter of time how she learns to hold and handle the babies. Reassure her that her body will produce enough milk for both the babies and generally to encourage the smaller twin to be fed first. And again, support and confidence is key to establishing breastfeeding. Today, we do see a lot of low birth weight and preterm babies. So this is a niche area where healthcare professionals have to focus. Any baby that is more than 34 weeks, initiating breastfeeding at the earliest is good enough. And these babies are actually receptive. But if they are sick or preterm, then special feeding techniques will be necessary and express breast milk also would be coming into the picture. Now, a weak suckling, easily exhausted baby and frequent feeding sessions would be the low birth weight challenges. So depending upon the gestational age, whether they are less than 28 weeks, then we know they are going to have poor suckling efforts and there will have some concerns in the gut. So the ideal feeding method would be intravenous fluid. 28 to 31 weeks, slowly they move into the nasogastric feeding and very rarely some of the babies are so active that they may be receptive to occasional pala-dye feeding. And come 32 to 34 weeks, encouraging spoon feeding, pala-dye feeding and cup feeding happens. If the baby is able to suckle, there's a lot of coordination establishment between breathing of the baby and how the baby starts swallowing. But beyond 34 weeks, most babies are able to establish a mature sucking pattern where breastfeeding becomes the key. So here in this picture, you see how the pala-dye feeding and the cup feeding is encouraged, where it is brought to the baby's lower lip and the baby is allowed to feed, but instead of pouring into the mouth, we allow the baby to get into the feeding process. These feeds may be long and slow and more frequent, but this is encouraged using the mother's expressed breast milk. Now, what if the challenge is a cleft palate? In a cleft palate, it is important for us to understand an obturator may be necessary, but if it's a cleft lip, holding the lip in a gap just using by the mother's digits, the baby can be encouraged to still take in breastfeed, but with the complete cleft palate, it is a challenge. Here, an obturator may have to be used, and guidance from the pediatric surgeon is also impossible. So how they manage feeding till the baby's lactation is going to be handled. So depending upon whether it's a partial cleft palate, the soft palate involvement, or the hard palate involvement, an obturator may play a role, or special assistance of early planning surgery may be necessary. Now, what about working women? Today, we have women who seek managing the family as well as managing their work life. So it is important for workplace facilities to come forward with breastfeeding rooms. And if such a facility is not possible, then there is expressed milk, breast milk option, where the supported family takes care using a bottle or pal-a-day feeds. So breast pump is something which is available as manual and mechanical. And today we have excellent mechanical breast pump options available. And the woman would be able to give up to 8 to 10 times feeds per day to the time of 3 months. So that amount of milk can be pumped out. We did see that the woman is capable of producing up to 2 liters of milk per day. And whenever she is home, she is to be encouraged to have direct breastfeeding. So in a workplace, when breastfeeding is encouraged, it is of course going to be a corporate image. It would reduce the maternity related leave. And if she's giving breast milk, the children fall sick less often. So again, it would prevent her pediatric visits for unnecessary infection, and it would retain the talented female employees. Now, for this, when breast milk is pumped, the woman needs to understand how to protect that milk so that it is delivered in the right way to the baby. If it is kept at room temperature, up to 4 hours, the breast milk can be used, the express breast milk. Once in the refrigerator, it should be in the 4-degree compartment. Up to 4 days, the milk can be stored and used. But if it is kept in the freezer compartment, that is 0 degree or lesser, then up to 6 months is ideal to store the milk. And once the milk is out from the into the thaw process, it should never be refrozen. And again, once taken out from the fridge, within a day it should be used. So these norms should be explained to the woman if she chooses to go in for stored expressed breast milk through the breast pump. Now, if the baby has not finished the milk, and it should be emptied within 2 hours. Otherwise, we have to discard it. We can't keep the milk in the bottle for more than 2 to 3 hours and reuse it for the baby. And particularly since the caregiver may not be the woman, she may be at her workplace, whoever is supporting her have to be getting these basic guidelines of storage. And if a woman has gone through some plastic surgery in the breast, either she's gone through a breast reduction or an augmentin surgery, and the nipple was removed or reattached, it will affect her feeding. So this is something we need to understand. And if a woman is on some antidepressants or she's on antipsychotic drugs, again, she cannot breastfeed. But ideally, it is important to treat the mental health as more important so that she is able to give proper care to the upbringing of the baby. And there are so many myths which act as deterrents, that I have too small breasts, or my breasts are too big, it's a premature baby, and the baby is preferring the bottle to the breast. So it's important for us to make them understand that too small breast doesn't mean too less milk. It is actually size doesn't matter. And generally, it has been an observation that more milk comes on the right breast than the left breast, and some women give this feedback as well. And we have to make them understand the size of the breast is mainly because of the fat, but the functional glands are as much present in a small rather than a large breast. So too, when most women feel they are not producing enough milk to the requirements of the baby, we have to encourage and make them understand if the baby is urinating well and passing stools, it means the baby is getting the feed. And we have to encourage them to take some galactagogues. In India, we offer them soft garlic, which are seen as good fenugreek seeds, as good galactagogues. We do have galactagogue preparation also, which is offered to women, and encouraging them that you will be able to feed and help the family to support, give them the privacy they need, and ensuring good latch. And today we have excellent lactation support nurse who would help these women to establish feeding and tell the mothers that each mother would be able to produce the right amount of milk for their baby. And even if woman is just having a mild cold cough or a flu, we have to encourage breastfeeding, because through her, the antibodies will give baby the passive immunity. And some babies do have certain favoritism, and especially they have a nipple confusion if they've been on the bottle feed for a long time. And for them to switch and adapt, it would take 6 weeks. The woman has to be patient. And if by being patient, definitely the babies can switch from bottle back to the breast. Now, failing lactation happens when the woman is into too much of caffeine, too much of smoking, alcohol intake, especially stress, lack of confidence, not taking care of health and diet, and if she's on certain medications which are directed into lactation. Now, how best can we help a mother as she's trying to establish breastfeeding? Insist that exclusive breastfeeding for 6 months, go for demand feeding, not put a timetable schedule and pressurize herself. There's no specific need that she should feed the baby for 20 minutes. Once the baby is pulling itself away from the areola, it means the baby's tummy is full. Finish feeding from one breast and then move to the other breast, and start with a different breast each time. And understand that preparing her for lactation is not after the baby's birth. It should start in the antenatal period itself, to be aware of breastfeeding, to prepare the whole family to do an antenatal nipple check if it's an inverted nipple, even if it is so, not alarm her and discuss about it. Most of the time it would sort soon after delivery. If not, you can attend it. Never break the confidence of the woman that she will not be able to feed. Every eager mother, every anxious mother should be taught, and latching, lactation nurse support, the obstetrician support, the pediatricians looking into that 2 to 3 days, first 2 to 3 days where the bonding is happening. It would happen. If they have any difficulties, the difficulties should be addressed at the earliest. And as successful lactation is happening, they need the appreciation words. You're a super mom. And that's why we do celebrate breastfeeding day, and we actually need to tell them doing it for 6 months is an amazing job, and to maintain it as long as possible. With this, I would like to conclude my presentation saying, let's promote, support breastfeeding. And this is not just about the health workers, it's also about family, friends, and society. So I hope we were able to cover most of whatever Madam wanted me to cover. And the rest, Neha, ma'am, you will enlighten us.
I think I was just waiting for the chairpersons to make few comments, and then I just thought, I think Dr. Shivaranjani. Shivaranjani, I think Madam Sumitra, Madam is finding it difficult to join. She's been trying, she's so much. But you should have told Saiti, she helps very well actually. No. It is because the network has a problem. There in the network. So just she moved from the hospital to the home, and she's feeling very bad. She's keeping on texting me. Okay. And so you can just have I'm here to make few comments. Actually, first of all, I would like to congratulate Rajpriya. What an exhaustive presentation you have done, right from the oxytocin reflex to the problems actually which ideally is supposed to be covered. So I'm very happy that you covered each and every aspect. For the oxytocin the reflex, you have very well said that it's the anterior and posterior pituitary both, and the two hormones, specifically the prolactin, which is responsible for the milk production, the baseline milk production, and the oxytocin is responsible for the milk let down, that particular reflex. So, the nocturnal prolactin secretion is maximum, and that is why the nocturnal milk secretion is also maximum. And that's why, some women complain of saying the baby keeps on feeding at the night. That is one. Secondly, I think the only aspect which I should stress here is initiation as early as possible.
the concept is nowadays delivering the baby on the mother's abdomen, irrespective of the mode of delivery, whether it's a cesarean birth or it's a vaginal birth, the baby needs to be delivered to the mother's abdomen. And even before cutting the cord of the baby, you just just support the baby, let the baby crawl towards mother's breast. That is called as breast con. The baby starts sucking on its own. It doesn't even require help. If at all the baby needs some help, then of course our staff has to be so well trained to hold the baby and the breast. And as you have rightly shown the picture, the catch of the breast, it shouldn't be a Caesar, not a V. It should be a C, the round, so that it holds the whole of the breast, and so the nipple and the areola automatically goes inside the baby's mouth. And if that doesn't go, then you just take the nipple closer to the baby's nose, so that you stimulate the touch the nose, so that the baby opens the mouth in search of the nipple, and then the whole thing you have to put right inside. So that is how the proper latch is. The techniques are, our staff needs to be very well trained. Why this is so? Because the good attachment is the only way. So initiation as soon as possible, and good effective attachment, or good latch that we call it as, that is very, very essential for the milk production and milk let down. Okay, so because the baby's sucking, baby's mouth is the best pump available in the world. So I would not recommend using any breast pumps. So just, gently stimulate the breast, and, you counsel her, pat on the back. Yes, yes, you're doing a good job, as you very rightly said. Maybe if at all she's having some pain, either you give warm shower or warm, compressions, maybe just a warm towel, you keep it. Or you can, after you feed, and then to minimize the pain, you have to apply what is called cold compresses, or even the cabbage leaves, simple cabbage, you just apply it. So that's the best effective analgesic, I would say. So that is how initiation and good latch. And then, of course, as you said very rightly, it should be a complete unrestricted feeding. It's not feed for 10 minutes, 15 minutes. It's not that feed every 1 hour or 1.5 hours. Not like that. It should be like demand feeding. Once the baby starts feeding, let the baby feed on both the breast completely till the breast is emptied. And then, of course, you hold the baby like this and pat a little, so that the milk settles down and the air comes up. So that is burping the baby, so that the baby doesn't get what you call it as vomiting. The mothers call it as vomiting, which is actually the regurg. And then, of course, the colics, the air colics the baby gets sometimes, and even the hiccups. So if you burp the baby properly, let the milk settle down, then the baby will have less of all these problems like hiccups and air colics, and even the rigors. How do you judge whether the baby has fed adequately? If the baby is passing urine 4 to 5 times a day, baby is sleeping for 2 hours after every feed, and the baby is gaining weight. So that is how you have to judge that, yes, the baby's milk supply is good. And only one last point I would like to make, that, it's the oxytocin reflex, what you stress initially, is very, very important, because there you have to know what are the factors that hinder it or that promotes it. So if the mother is, happy, she doesn't have much of pain and anxiety or stress because of anything, then she will have the best of the milk supply, because positivity, oxytocin is a happy hormone. And if the mother has pain, anxiety, lots of family stress as well, nobody is there to support from the healthcare provider, or even the relatives or the family, then of course that will lead to hindering of the reflex, and that will lead to lots of queries whether the baby is feeding well, whether the baby milk is adequate for the baby. She will directly say, no, I'm not getting any milk, and the baby is getting into problem, so I better avoid, give him top feed. So that is what we have to support, that first 24 hours. Maybe when you check, the milk supply may not be there, but when the baby, sucks at the nipple, then the reflex initiates, and then the milk is automatically let down. So you need not worry whether the mother has milk or no. I think that should be all. You have covered the problems very nicely. I'm very happy that a person from your side speaking so well. I'm really feel that it is very inspiring. All the obstetrician should learn minimum this much, because you may not have lactation consultant at every place. So I think that should be all. And once again, I congratulate you. Thank you so much.
Thank you so much, ma'am. Thank you, ma'am.
Rajpriya
Thank you,
does
my dear
everything
Jayarani.
perfection. Rajpriya is our, we are all in the EC, and she's a great person in IFS, and she's very, very much comprehensive in everything, whatever she does. And
Perfect.
yeah.
Thanks.
Perfect.
Great
So thank you,
appreciation.
Jayarani, once again. Thank you, Madam Revati Janaki Raman, for blessing me always. And I just request all the societies, president, secretaries to, support me. At present, nominate me and support my candidature. And of course, all the members, I can see Priya, all the members to vote for me as Foxy Vice President from very soon. Thank you so much. Hello, Dr. Priya. Hi.
Sumitra madam has joined? No. Okay. So that's so wonderful, and that's so nice that we had a very great deliberations, or rather we can say as an oration about lactation with both the breast committee chairperson, past person, and the person who is really passionate to talk, that is Rajpriya. Both have made this session a very interesting one, and we are now awaiting for the most dynamic panel, which is the one which is going to be moderated by my mentor and my teacher and my guru, rather, I can say, Dr. Revati Janaki Raman madam, to moderate this panel. And we have the chairpersons for this session. Do we have chairpersons there? Brijbala is here. She said that she'll join at 8 o'clock. So I think Brijbala is a very young and dynamic committee chairperson of Foxy. And she's actually from Indore. She's the past president of Indore, and presently she's the committee chairperson of Foxy. I think Brijbala is here. I don't think she's there. So I have the great privilege of introducing my madam, Dr. Revati Janaki Raman madam. Can I have the CV of madam? Yes. Madam is the founder secretary and the past president of Madurai OBGYN Society, and she's the founder president of Madurai Menopause Society. Anything in Madurai regarding the OBGYNs, madam is the beginner. She's a great teacher, great academician, and great dancer, and great person of all capacity, all the extracurricular activities like singing, dancing, a lot of things on her credential. And she was our Foxy vice president from South Zone. And she has the Pride of Foxy Award in November 29 at Mumbai. And she has contributed to so many books of undergraduates and postgraduate books. And she has authored many books, and she has presented very many papers. And she's the Lifetime Achievement Award of Top Tapizar. We gave her this November 2024. And she has the Academic Excellence Award from the Madurai Medical College. And she is the very greatest alumni of our Madurai Medical College. Over to you, madam, to moderate this wonderful talk. Wonderful panel discussion. And we have with us Dr. Kunjumoidin sir. I think sir is just gone for a condolence of his anesthetist father. So he's just called me. Sir is the past president of Kerala Federation, and who is the present president of the Perandalamma OBGYN Society and the joint secretary of the IFS. And he'll be an expert. And we have one more expert, our dear Jyoti, who will be talking on many things related to the medical legal aspects, even about the vaginal birth or the cesarean section. And she's can I have Jyoti's? Yeah. So she's 28 years of experience. She's the vice president of the Indore OBGYN Society in 2022. And she's the chairperson of the Ethics and Medical Legal Committee of Foxy, and the treasurer of IO Indore OBGYN Society 2019 and 2020. And she has edited very many books in the medical legal manual workshop of AACOG 2022, coordinated the workshop too. And she has been the recipient of so many awards and published many papers and conducted various educative and awareness campaigns. And she has been an invited faculties for the very many national and international conference. Very young and dynamic chairperson, Jyoti, who will be the expert for this panel. Madam, over to you to introduce your panelist. Or can I do, or Madam, will you do?
No, I think I can just mention. Okay. Thank you very much, Dr. Jairani, for your kind invitation. And I'm very happy to moderate this session connected with the Mother's Day. And I have got a galaxy of panelists, Dr. Vandana Gupta, President Cogs. She is Katni OG Society, Director of Om Shanti Maternity Hospital, and she is interested in HPV vaccination, cervical cancer screening, as well as high-risk pregnancy. Next, Dr. Nidhi Bajaj, Secretary of Katni OG Society. Next, and who else? Next, Dr. Sunita Chauhan, gynecologist and obstetricians from which hospital? From Indore. Okay, and she is Secretary of Indore OG Society. And Dr. Komal Jain from Jabalpur. Next, Dr. Sunita Vadwani from Ratlam Obstetrics Gynec Society. She is president there. And she's a Dr. Priya Kandapan, our own TNFOG and Oxy member, best outgoing student. And Nidhi Jain, from which place? I don't know.
Madam from Ujjain.
Okay. Next, Dr. Archana and Dr. Who else is there? That's all I think. Okay. Can I share
also
my...
from Ujjain, madam.
Okay. Thank you. Okay. Dr. Jairani has given me two topics. One is the discussion about birth plan and decision making, which is really, it is easy to talk, but difficult to practice taking a decision. And as TNFOG president in 2023, the theme of that year was Mavichana Magaperu Maranamilla Magaperu. That is joyful pregnancy and without any maternal death. That is the thing which we are aiming at. Now let us see what best we can do about it. So to set the ball rolling, I'll ask Dr. Priya Kandapan what is actually meant by birth plan. Priya?
Ma'am, usually, like, though we don't practice in our place, like when this topic was there, I just saw, like, actually in the RCOG, they usually do the birth planning, madam. They have a discussion around 34 to 36 weeks. Usually in the 36 weeks visit, they start planning the birth, like discussing all the pros and cons, where it has to take place, because they do the home birthing also. So whether it is in the home birthing or midwifery center or consultant-led unit, and what is the, like, mode of delivery, and it can always change. What are the women's preferences? For example, if a woman wants now, like she wants to try vaginal and then she changes also, that can also be there. So they just plan accordingly so that it is a combined discussion between the obstetrician and, if at all like high risk pregnancy, then a multidisciplinary team along with the women, and also giving preference to the women's choice as well.
It's actually a written document outlining a pregnant woman's preferences for labor as well as birth. It's a really, as you said, really a tool for communication with the healthcare providers. Actually, first, the written guide of birth plan was introduced in 1980. Now, Dr. Vandana, is she there? Dr. Vandana? If not, Dr. Nidhi Jain, I saw her here.
Yeah,
now, what
Nidhi
is
was
the
there.
purpose of this birth plan, Dr. Nidhi? Is she there?
Madam, Dr. Sunita Vadwani is here. Madam Sunita.
Okay, anybody can answer.
Dr.
What is
Nidhi
what is the purpose of this birth plan?
The purpose of this birth plan is to reduce the maternal mortality rate and to find out whether the delivery will be normal delivery or it may convert into cesarean section, and whether the patient is having any high risk factors for the delivery like hypertension, diabetes, or any comorbidities. So the birth plan is necessary to predict the outcome of the delivery.
Yeah. And also that it empowers the woman to communicate her preferences as well as expectations. At the same time, ensure a safe and positive birth experience, whether be it cesarean section or vaginal delivery. Even though we can't predict everything, a well-crafted birth plan is all about preparation and open communication, as Priya rightly said in the beginning. Now, who else is there? What are the components of
Madam
birth
is
plan?
there. Nidhi Bajaj is there.
Nidhi Bajaj, what are the components of birth plan?
Unmute, ma. Unmute.
The birth plan. Can I speak?
Yeah.
Yes, madam. Yes, madam.
Yeah. In the birth plan, you just have to communicate with your patient, and she need to know her doctor well. She needs to know the staff around her who is going to be there with her during her laboring phase or the cesarean phase around. She needs to know the place where she is going to be giving to the birth. And we need to ask her about her preferences, and we should make her familiar with the kind of pain she would have and make her mentally prepared for the delivery.
Actually, we have got I didn't put it here. There is a sample of the birth plan document, okay, in which the name, the expected date of delivery, and all these details, what are all the preferences, everything is written as points, and just she has to fill it up, okay.
It is
Now,
just about making the
very
patient comfortable.
But the main things, components are the birth location, as you rightly said, where she prefers to have her delivery, and for the support persons
Who she wants to be accompanied with.
Labor preferences, then pain relief, what type of pain really she wants is, because many times some patients will say that I want to enjoy the pain. Sometimes the patient specifically want to get rid of the pain, and the mode of delivery and the care of the newborn. So these are the major things of the birth plan components. Now, suppose we are going for a vaginal delivery, as a healthcare provider, as a doctor, as a obstetrician in charge, what are the key considerations about the birth plan in vaginal delivery? Dr. Sunita Chauhan?
Yeah, the key considerations for the birth plan of the vaginal delivery. So whether the patient will deliver normally, so we can give the options. Either the patient can feel the pain, or there may can have epidurals, and the proper environment, that is light, music, temperature, what patient prefer the position, whether she can deliver in supine position or in birth positions like in water birth, if you have, and to check about the blood sugar level, cord clamping, and to wait for the cord clamping if the patient is having any problem, and avoiding any interactions like avoid unnecessary
nowadays
interventions.
people are asking for lotus birth and all, no? So that is why the cord clamping. Okay.
And to avoid any unrequired interventions like episiotomy if the baby is smaller in size and the the vagina is roomy.
Because women are so intelligent that they even otherwise, they just discuss with the neighbors and they want to know whether they will have some trauma in the perineum or that will be painful. So all these things they are worried about, and it is up to us to clear their doubts.
Explain all the things.
C-section, what are the considerations for the birth plan?
So if it's for the cesarean section, we want to know whether she wants a supporting person like a husband or some birth companion with her. Some people may refuse, some people may do that.
You always allow?
Actually, madam, I have tried, but there are certain hospitals, they have strict policies not to allow. Some hospitals allow.
How acted in that situation? The patient insists on her husband to come inside the theater, but you cannot allow. How will you
Yes,
manage
ma'am.
that?
So sometimes what we do is after giving the anesthesia, madam, and once the patient is draped, then we try to bring the husband, make them sit with the patient, and till the surgery is over, not to get up and see anything. So that is how we tackle. But sometimes our hospital is very strict on not allowing attenders at all. So they say
that again we have to explain to them earlier, and also you can tell them that maybe the anesthetist or the hospital rules are like that. So it may not be possible. Okay.
Yes, some hospitals do, madam. Like sometimes what they do is initially they allow till the baby is delivered, and once the baby is delivered, then they shift the husband along with the baby.
Even vaginal delivery, the husband wants to stand nearby, and mainly for the support of the wife. Okay. And
Usually
only
we
then
try
when they
to
see
sometimes
the
it helps.
struggle of the patient, only they will know how the pregnancy and delivery, which is undertaken by a woman, They will know the stress.
I still don't think they understand that much, madam. They are just there. Sometimes they are curious what we are doing, so they never see their wife at all. So they just go around to see what all is happening. So,
So you
like
mean
that
to
way,
say
I'm not sure,
allowing
but
a supporting person either for section or vaginal delivery is not a favorable one for the obstetrician.
yes, but it is like, it helps to calm the patient. Sometimes the husband motivates. So he says, come on, push, push, push. And like it really works. So, like all the biting, scratching, he can get it. So the
Okay.
staff is little safe on getting those scratches, and the husband can get the scratches. So that we can allow him to do that.
Yeah.
A tender loving care they try to give. Nowadays, the recent couple, they want to give that, madam. So even the
Okay.
husband insists, like they want to come
Yeah.
inside.
Yeah. And many a times,
So
especially when they are doing it under regional, they want to see the baby immediately, isn't it?
yes.
Yeah.
Yes, ma'am. Yes. So then we
Anesthetic
try to
also
drape
doesn't
them
sedate her
basically.
till then. Okay.
Yes, because the anesthetist also believes that hearing the first baby's cry, it make, like that feeling is like, it cannot be missed for the patient. So even if she's training, they don't sedate her till that.
Yeah.
And the cord clamping, as you said, madam, whether the patient wants to have the placenta retained tied to that natural birthing is not about cutting the cord at all. So it is about having it, and like, the cord totally falls along with the placenta. So if those are the preferences, I don't know, madam. I'm not a person for natural birthing, but some people are still doing that. And pain
Storage
management.
again, you should have discussed earlier if at all the patient is
Yes.
interested.
Yes,
And
ma'am.
of course,
And pain management, like very rarely we need epidural continuously. After
yeah.
that, most of the time we give with all these IV analgesic, and like, immediate breastfeeding in some setups we really try, madam. We bring that, we drape the baby, and immediately while we are doing the cesarean, like they come and they put the baby on the breast and they feed. So
That-
it is happening in some of the centers.
That is very, very important. Especially many women have got the doubt that after cesarean section, they may be able to feel only after a day or two or something like that. They want to wait for some time. So you have to clearly tell them that it is immediately possible. That is very,
Yes.
very important on our side. Okay. Now, birth plan, you said you are not using it, but anyway, does it have an impact on patient satisfaction? What is its impact on patient? What is its impact on the obstetrician? What is impact on patient satisfaction? Anybody else? Dr. Sunita?
Yeah,
Yes,
ma'am.
ma'am.
If you
It has a
talk,
very
yeah, please continue.
It has a very good impact on the patient satisfaction. If we explain everything to the patient, then patients are ready to bear all the things that is happening, and she can enjoy during labor, either during normal labor or during cesarean section. And it is very good support to the obstetricians as well, because she has already explained all the things previously. So she can support whether it is normal or it is cesarean.
Oh, yeah. But the degree of satisfaction may be related to the number of birth expectations that are met in some cases. Okay, that is again very important. What are all the things? Now, does it have an impact on the perinatal outcome? Suppose you follow this birth plan. Now, we want to know how much it is going to be beneficial in our setup. Okay. Now, what is the impact on
We
perinatal outcome?
usually we talk about the baby care, we talk about breastfeeding, and that is where it makes all the differences. If the patient knows how she has to go about with the baby care and how much of pain she's going to be having, then it becomes easier for her to get ready for all the post-operative or perinatal outcome would be better.
Yeah. That's what very studies have shown, that there is an even decreased rate of cesarean delivery when they have got the birth. Mentally they are prepared. Okay, so that is the thing. But this is mainly only in primaries, not in multi-gravidas. Okay. And most importantly, the provider perspectives. We as an obstetrician, what is your opinion? Is it useful for education and shared decision making, or it is not useful or even harmful? What is your opinion about it? Birth plan, practice in our setup.
It is very useful, ma'am.
Mm-hmm.
It gives you an opportunity to be comfortable with the patient as well as the relative, and you would know about what the patient's psychology is going through. At times they are all, and I mean, having a tremendous Google knowledge, which is at times not right, and they can ask you their
See, actually, have you seen that birth plan document, that model, all the points 1, 2, 3, 4, in which they are
Yes.
filling it up and they're keeping it ready. Of course, when they bring it like that, it is the responsibility of whoever be the healthcare provider, either midwife or the obstetricians, to answer all those things and fill it up. Okay, so that is very important. But how far it is practically possible? Any idea, Dr. Priya or Dr. Nidhi? Whether you are for it or against it, birth plan.
Like sorry madam, I'm back. So like sometimes they even ask you, like, do you want us, like, I mean, in the abroad, they ask you whether you want the colleagues to handle you, whether you want the students to be around, videographs. We are not used for certain things in our setup, madam. But patient expectation is that they want to go directly on Insta Live to have a birth planning, and that is what is there. And suppose if there are legal consequences later on when we allow a video, we don't know what it is. So there are certain things, like, there are limitations where we cannot do everything what the patient wants. For example, we know that abroad they give the water birth. In India, we are not very sure. First of all, there are few centers which is tried, and they have also stopped because the infection rate in our country is very high. So we cannot give. And suppose if something goes wrong, our people are not very acceptant. For example, if there is, like, if there is a perineal tear, a complete perineal tear, or something goes wrong, if the baby is having some other issues, the patient is not, the anxiety level for the patient is very high, madam. So it is always a weighed decision, and it depends, like, you have to have the time, sit and tell them what all can be possible and what all can go wrong as well. So, like, they cannot have that very high expectations.
There are two things I want to clarify now. See, say for example, in a government setup, in a government hospital, do you think that it is possible for all those
No,
village
because this is
rural
only
areas,
for
even
one-to-one care,
rural
madam.
areas? Is it
No,
possible? Highly impossible. So in that
impossible.
setup, it is highly impossible, right? And second thing is that this written document is possible only for an educated person. Okay, so that is
Yes.
another thing. That is one important thing. That is why we cannot make it as a routine in our setup. Now,
Yes.
actually, there was one study in Jan 2025 in Bangladesh from the healthcare provider, especially the obstetricians, and they have found that though the birth plans are predictive of adverse obstetrical outcomes, that is what they think, and also it is by birthing person to control a process that by nature they cannot control at all. So they are thinking that they can control everything. So that again is another negative point. And also there is increased maternal anxiety and as well as interference with the patient care. And again, they found that the negative emotions such as disappointment when the birth plan was not followed. Exactly what you said. Okay. And some providers may feel a loss of professional autonomy. We are talking about patient autonomy only. Professional autonomy, or perhaps a heightened sense of medical liability related to adherence to the birth plan. These are also there. Okay. So that is the thing. So with all this thing, anybody else would like to share your opinion for or against a birth plan? Should we have it or not?
Madam, it can be even equivocal because it depends upon the literacy, it depends upon the patient's, I mean, education and their
even
knowledge.
Then, everything okay, literal literacy okay, everything okay. The patient is for it and she is bringing a birth plan. Now, as an obstetrician attending, you would like to encourage it or you don't like it at all?
Ma'am, we have to educate them, ma'am. We have to educate them. We have to tell them what are the pros and cons, and we have to give them all the what are the probabilities and possibilities with their conditions and what negativity can go on in any situations, how it happened. And sometimes we have to quote evidence-based things that what happened in the past also.
So
maybe
exactly.
to make them aware. And also it's a very, very difficult situation, ma'am, because our setup and all, we are it is not a corporate or it is not a
government.
I mean, government setup and all. So when it's a private, it also matters about the private and the government. So all the matters of responsibilities, responsibilities and taking the legal litigations, everything will matters a lot. It may be in the future, but not at present. It is
So
still
even that ultimate point is that we have to spare some time to counsel.
A lot of counseling. Yeah.
True.
Discuss with the patient, gives ears to the patient, listen to them, and whatever questions they ask, you explain to them. These are all the things indirectly birth plan, not exactly the documentation, like whichever is feasible for us. You spare some time to counsel, talk, and then clear all their doubts. which we are unable to do many
Usually, the
times.
medical concept we can always guide, madam. Like all these, like whether they want anesthesia, epidural, or they want TENS,
No, other
or
things
they want other
that is why I
things.
said other things also we have to counsel. So the patient's comfort. Patient wants this lotus birth.
Yes.
Patient wants no, she wants pain or she does.
Birth at squatting position, birth at sitting
Oh, yeah.
position. I don't know, madam. So,
So these things
they want those things.
Dr. Jyoti, are you there? What is your opinion?
Jyoti, I don't know. She was there only. Yeah. I'll call her.
Okay, then we will see. Right. Then we go to the next part of the discussion, that is decision making, which is very, very important. When I took over the post of director in IOG, I was surprised to see this bell at the entrance, and I was told that this bell will ring whenever a cesarean section is going on the theater, and all students will rush to the theater. But I think nowadays, only when the normal delivery,
it's so rare.
The bell has to ring now. Okay, so making a decision whether C-section or normal delivery is really a dilemma and depends on various things like social demography, cultural things. Most important thing is the health care factors. We have to make a correct decision. And again, every nook and corner, we are talking about reducing the incidence of C-section rate. And this point, I want to emphasize that in the FIGO Ethics and Professionalism Guideline 2020, they have given clearly how to make a decision about vaginal or cesarean delivery. Professionally responsible decision making with patients is based primarily on the ethical principles of beneficence and respect for autonomy. The physician has the beneficence-based obligation to identify and present the medically reasonable alternative for the clinical management of the patient's condition. So this is the very important thing. When you will recommend vaginal delivery, when there are no evidence-based clinical indication for cesarean delivery, vaginal delivery should be recommended. When we recommend cesarean delivery, it should be recommended as the only medically reasonable alternative if and only if there is certainty of an evidence base for the clinical judgment that cesarean delivery is clinically superior to vaginal delivery. Whereas every obstetrician will think or make that cesarean is superior to vaginal delivery for the particular patient and they jump for a C-section. But we should not do that. Okay. And I'll just bring out few cases and how we are going to manage that. Okay. Now, this all are my own patients. Primi, 29 years, she's a daughter of a surgeon, and the surgeon, my teacher, the surgeon, she demanded that he wants only C-section for her for the auspicious time and date of delivery. What will you do? How will you approach her? What are the other reasons for demand? This is the main thing many times, because they want to get the baby born only at that particular time for Jatagam and all. There are other reasons also. Now, how will you manage such patients? And what are the other reasons? Sunita?
Yes, ma'am. First, we will make patient understand whether the cesarean section is fruitful for her or not, and whether it is indicated or not. We should explain the pros and cons of cesarean section also. And if still the patient insists for the cesarean section, and because of the fear of the childbirth, we can take the patient for cesarean section. And simultaneously we'll tell the that if she doesn't want to have another child, we can do tubectomy also.
Yeah. But when they come with this simultaneous tubectomy, so they want a C-section, you have to explain to them, because many times our patients are more worried and they think that tubectomy is the biggest surgery, not even cesarean section or hysterectomy. So you have to clearly explain to them what is what. Okay, that is very important.
And we'll get everything in written from them. We'll explain them and we'll tell them that normal delivery is possible in your case. If we can try for a normal delivery, still, because you are asking for a demand cesarean section, we have to get that written from them.
Okay. So we have to prioritize safety as well as evidence-based practice. So you have to explain to them. That is very, very important. Okay. Now, as an obstetrician, as a caretaker or a healthcare provider, what is our role when they ask for or when they demand cesarean section? Even though vaginal delivery is possible.
So if there is only a fear factor, we can just counsel them, tell them, reassure them. We can give them option of labor analgesia, and then I mean, like, just make them understand that as cesarean section is not totally pain free, and it has long term health. I mean, like, complications. Suppose if you goes for that, adhesions, chronic pelvic pain, everything are common with cesarean. So it should be done only for medical reason. It's our duty only to explain. But finally, I think all of us will agree we give in to what the patient wants, madam. So if it is like, she's very particular, no, I want this only. So then I think most of us, we just give it. Or otherwise, you can just say that I don't do it by principle and send it to somebody else. Anyway, she's not going to change and going to deliver. So either you do it or you refer it out. That's all, madam.
Okay, better you do it and get the benefit. Okay, but as FIGO guideline 2020 says that the goal in responding to a patient's request should be to transform it into an informed decision about the alternative. Okay, that is very, very important. And also we have to ask her the reasons why she wants cesarean section, listen to her and correct her misbelief, and also you have to give her respect to her feelings also. Okay.
Sure.
Preventive ethics starts right from the antenatal period itself. Okay. There's another patient, 30-year-old IVF pregnancy, size of the baby is only average. How are you going to deliver her? Is it that previously you say one cesarean, always cesarean? Like that once IVF or ART pregnancy, always cesarean section. Is it so? Or is there any chance of delivering her vaginally?
No.
No, not actually.
But
Once
actually,
once they conceive with the IVF, they should be treated as a normal patient.
Yeah, that is very, very important. See, till the achievement of pregnancy, IVF is very, very important. Once she becomes pregnant, she should be treated as any other
normal patient.
Like same thing, any medical complication, whatever happens, should be this IVF per se should not be an indication for C-section. Okay, that is another important thing. But many a times, ART specialists, forgive me,
Madam, basically, no, madam. Even if we tell them to exercise, move around, patient will not move at all. They are totally, completely bedridden for 10 months. And when it comes to induction and delivery, they go in for prolonged labor, waiting for 2 days. Your baby's head doesn't come down at all.
Counseling is not sufficient. You know, one thing, one of my IVF patient, she used to swim and all. At 8th month, she said, I would like to continue swimming.
Lovely. Madam, you are lucky, madam.
Enthusiasm they have got.
You are very lucky, madam. She is a swimming girl.
And of course, unfortunately or fortunately, I delivered her bisection because she had preeclampsia, GDM and all sorts of okay. Now, the key considerations to decide are like it should be an individualized approach. You have to give the preconception and pregnancy care, and you have to communicate with them properly. Okay. And this another patient, she is gravid of 6, previous 2 first-time abortion, 3 mid-time abortion, which is typically cervical insufficiency. All these things happen somewhere outside, and cerclage was done, I think at GH, I believe. Okay. And they planned for elective section because she doesn't have a live baby. Is it justified?
No. She has cervix which can be dilated so easily.
No, cervix.
The basic problem is cervical encirclage patient, madam. We can dilate the cervix, but most of the time, what we see is the head never comes down. The descent never, it doesn't happen. Even if it's a small baby, it doesn't happen easily. We wait and then we end up with section only, even if you try for cervical incompetence.
So and most of the cerclage is that
in such patient you go for an elective section.
Very scarred, ma'am. It won't open that way.
We can remove the cerclage at 38 weeks of pregnancy, and we can wait till the labor start. If the labor doesn't start till 40 weeks, we can take her for cesarean section.
That's what I too feel. Because we need not take her up straight away for section.
Here we'll again discuss the birth plan with the patient and what the patient wants. We all go by that, madam. With 6th pregnancy, 5 losses. Yes. The patient says cesarean section. I don't think we can sit and say, no, come normal. Something goes wrong. She comes and says, I didn't ask at all. This doctor only told me to try.
But many times the ball is in your court. Madam, yes.
We will not do induction.
Yeah, we should inform the patient about all the probabilities.
Yeah, exactly. Okay. This another patient, 26 years old, grabbed her to para 1 LCB 2.5 years, previously section for fetal distress. Now she is term cephalic presentation, ultrasound 2.6 kg only. Now, what are you going to do? Decision.
VBAC, sir, madam.
VBAC.
How many of you have conducted VBAC in the last
Again,
1 year?
Madam,
The last
I do,
1 year.
madam.
Ma'am,
I
again there is
genuinely
a
try,
role
madam.
of
Postgraduate period
birth
only,
plan.
ma'am.
Again, there is
Madam,
a
I
role of birth
genuinely
plan.
give, madam.
Labor ward only, ma'am.
I think VBAC is only in paper, not in
Madam,
practice.
I try, madam. I put Foley. Cerviprime sometimes I put, but most of the time I put Foley. They go into labor, but somehow at 4 or 5 centimeters, they start screaming so badly that my scar site is painful. Then you get scarred that, okay, the scar is going to give way and we land up in section somehow. But I really
So VBAC is only when the
to
patient
give,
comes with the head
madam.
at the outlet, you allow her,
One or two
allow her a
years
vaginal
succeeded,
delivery.
madam. But success literature states. Yes, I allow, madam. I try, I induce also.
Okay, okay, that's
No,
good.
I will not induce. If patient comes in labor and delivered normally, then we can do.
Priya, when will you induce the previous cesarean?
Madam, I wait till 39 weeks, madam. Very rarely I've given up to 40. At 39, I try and induce, madam. Sometimes the scar becomes so thin, it's very scary to wait after that. So I just induce. I put them like a Foley balloon and this one, madam. Sometimes they go into labor only with Foleys. And they deliver also, madam. So
previously, we used to say that in previous cesarean, only go for, if at all she gets into labor, you can accelerate, but not go for induction, because when there is an indication for induction, that indication plus previous cesarean equal to repeat cesarean. It comes like that. Okay. So many a times the present generation always they try to find reasons to end up in section, but that should be avoided. That's why we are discussing all these things. Okay. Where is the next thing? Why it is not moving? Yeah. Okay. What is wrong? Just a minute. I have come. IVF pregnancy, they have finished. Yeah. The previous C-section, of course, theory I'm not going to discuss about. All the indications for vaginal delivery. But meta-analysis has shown that it is the health professionals' influence on the women's decision making. What we are guiding, that is very, very important. We should have the skill to provide supportive care in shared decision making, debrief women regarding the indication for the primary cesarean, address issues of safety, fear, expectation of childbirth, and all those things we have to explain. Many times that we ourselves are not convinced. We ourselves are not very happy about allowing them a vaginal delivery. So the doctors with negative views of VBAC focus on risks, either of the women or for the doctors themselves. So that risk they don't want to take. That is why we go for a repeat C-section. But it is really advisable, if everything is favorable, VBAC with all the precautions, we can allow them a vaginal delivery. Okay. So these things all of you know. Okay. And second of the 10. Nowadays, I find that many indications, many sections are done for the second of the 10 when it's a noun vertex presentation. Now, actually, this shows a gravid 2, para 0, abortion 1, twins term, first baby delivered vertex vaginally, and second twin was transverse light. And for quite some time, she didn't progress, so they took her up for section. Now, is it advisable? What decision should have been taken? Dr. Sunita or Nidhi? Immediately after first, what should have been done after the delivery of the first baby?
And we will
We
try
should
to do
direct her head down.
Yeah, we'll try
internal
to do
suprapodal
internal podalic version. We
version.
will
Yeah,
hold the legs and we'll deliver the baby.
we'll deliver. I mean, we'll get the legs. Yeah.
That is very important. I can never forget the teaching, what I used to teach my students. In twins, after the delivery of the first baby, immediately you palpate the abdomen, map out the position of the second baby, then find where the head is and bring it down, do the external cephalic version, do a PV, controlled ARM. The head will get fixed, automatically she will deliver. Otherwise, you have to go for a membrane rupture and IP version and deliver. Okay. Unnecessary cesarean section can be avoided in such cases. This is the last case. She's a primey in labor. This case I had in IOG. As soon as you know one thing, the assistants always inform the chief in such a way that when they will take the decision and then inform about the patient in that order only. Okay, many times it happens. Some assistants are small.
Madam, that is always should be there, though, ma'am.
Okay.
Prima facie is the person who does everything, no, ma'am.
Okay. This assistant told me that the primary is in labor for quite a long time. 6 centimeters, she is not progressive. I'm taking her up for section, madam. I said, any other complication? Nothing. No CPD, nothing at all. Okay. Then I said, okay, because I used to do rounds first in the labor ward, then only I go to my room. So I entered the CRT and then I found the patient. She was prepared and kept in the stretcher. Then I said, she was on the oxytocin drip also. And just on looking at the abdomen, I found that subumbilical flattening.
Yeah.
And clinically, inspection itself, there is no CPD. Okay, I did a PV, 6 centimeters dilated, membranes absent. I could make out the suture line. It was an ROP. I just told her that you wait, continuous intostin on drip. I'll go to my room. By 10:30, you will inform me that she will deliver. Exactly by 10:29, she told me that she delivered vaginally. So, thing is that many a times a prolonged first stage, you are missing the occipital posterior. That you should remember. And again, the same thing is that when you allow her a vaginal delivery, the possibility of in an occipital posterior, if she doesn't rotate or reverse rotation, phase to pubis again, the perineal support, proper perineal support, and if at all you are going to apply forceps, the care you have to take, and all these things, everything should just flash in your mind when you are conducting the delivery. So that is the thing. And suppose second stage prolonged, what will you do? There again, many times the increased cesarean section rate for prolonged second stage. And second stage cesarean is very, very difficult, even worse than a vaginal delivery. Okay. Now, how are you going to manage the prolonged second stage?
So it depends upon the station where it is.
Okay. So actually, when I was PG, MD PG, there was a case of actually she was a second grade, I believe, and full dilatation, and it was just at the spines. Okay. And if she pushes, during the contraction, it just comes below the spines. Okay. There is no CPD also. And full dilatation more than 1 hour. I decided to apply 80. At those days, we put right and left axis traction forceps, mid cavity forceps. Okay. So I planned for forceps, but PGs were not allowed. I was a DGO PG, I believe. I was not allowed to do apply forceps without any assistant nearby. The assistant, when I called, she didn't come. When chief came on rounds, she immediately scolded me. Why you are waiting for more than 2 hours after full dilatation? So you should have applied forceps and delivered. So this is what you learn. Okay. So this patient, do you go for a cesarean section unnecessarily because she hasn't delivered? If there is a possibility, you can deliver. Of course, with vacuum nowadays, you are not going for nobody is now efficient in 80 forceps. Okay.
Yes, ma'am.
Vacuum and then delivery is possible. Okay. And how many have you delivered like that? Second stage delivery delay?
I have tried many, madam, but most of the time encountered with shoulder dystocia, few of the Erb's palsy, and like then the neonatologist open commenter who asked you to give this kind of normal delivery for big baby and 3.74 kg.
That also you should consider. That also size of the baby also you should have planned earlier.
Yes.
Where you have to anticipate.
Like sometimes there is a component of this cord around the neck, madam.
Yeah.
Yes, cord around the neck,
all
they
these
usually
things you have to
never descent at
identify.
all. So those things, when you pull it up with vacuum, they usually, the small size babies, you don't have any complication at all, madam. The babies really do well. You can just put a vacuum, they come out well, and then you just deliver like remove the cord and just pull out the baby. The small size babies, you don't have problem at all, madam. Sometimes we even put vacuum for the bigger ones also. So these 3.7s and 3.5s and other things, and they get caught with the shoulder, and you anticipate shoulder dystocia, and then you go with the maneuvers, and then you deliver them.
Many
But
cases
sometimes you do regret.
Many cases I have done in labor ward, applying vacuum, rotate, and then ask the assistant to hold that, and then apply forceps and then deliver. That also we have done long back. Nowadays we don't have to do that. That is a different matter. Okay, so remember one thing: prolonged second stage, you don't allow. Anticipate earlier, and if at all it is required, as she said, in a big baby where you anticipated shoulder dystocia, take her for a section much earlier, which should be more convenient and less damaging. And if you find that everything is normal and she's going for a second stage prolongation, then you have to try for a vaginal delivery. Okay. So, effective measures in preventing distortion, subsequent cesarean and unnecessary cesarean deliveries. Of course, you have to avoid admission during latent labor. This is what they do in abroad. And provide cervical ripening. Encourage continuous labor support, walking, upright positioning in the first stage. Not diagnosing failed induction during the latent phase until effective oxytocin is given. That is very, very important. Namkeva strip and then or without knowing how effectively it is given, prolonged stage, take a repo section. These are all the areas which we have to focus so that we can minimize the cesarean section rate. And of course, as I told you earlier, recognition of occipital posterior. So to conclude, whenever you take a decision for vaginal or cesarean delivery, these are all the areas we have to focus. Now, ultrasound cord near around the neck, don't jump for cesarean section, which many times the periphery doctors do. That is why I said, Dr. Suresh, one time that please don't mention this cord near the neck and all those things. Okay. And provider convenience. I want to go to some holiday trip, so I want to deliver her immediately before I leave. So I have to that also. Many a times it is being done. And patient preference, of course, we have to give, but we have to counsel and explain to them. Labor dystocia, I have already told VBAC also. Induction of labor again. Be very clear that she will deliver and then go for the induction. Unless it is not favorable, you don't go for that. Bad obstetricity and ART pregnancies we have discussed. And isolated oligohydramnios. What decision you take? Many a times, because water is not there, so take a upper section. And isolated oligohydramnios is not a major issue. If everything else is normal, you can allow her a vaginal delivery. That point also to be taken into. And instrumental deliveries, vaginal delivery, normal delivery only everyone is very familiar with, whereas instrumental delivery now, the art is now totally weaning off, which has to be revived. And of course, how to interpret the CTG. That is again very important. Immediately jump for section is to be avoided. Maternal request again depends on how you convince them and how you have to budge to them. So all these things you have to take into consideration while making a decision whether a vaginal or a cesarean section. So thank you very much, all my panelists. We had a nice interaction. No theory, only practical points. Thank you, Jairani.
Thank you, ma'am. Thank you.
Nice opportunity. Thank you very much.
Thank you, ma'am. Thank you.
Thank you,
really
ma'am.
enjoyed.
Thank you,
Jairani,
ma'am.
Thank you,
Jairani, like we were taken to the class, like an old class.
Yes, madam. We really, it's a lovely panel, madam. Thank you, Revati, madam.
Thank you so much, ma'am. Thank you very much, ma'am. And on behalf of TNFOG and all the societies of Madhya Pradesh, I thank all the senior faculties, right from Madam Madhuri Patel, madam, and all the guest of honors, Dr. Rosa, madam, Dr. Kavita Bapat, Dr. Asha Bakshi, and Dr. Vidya, and my dear teacher, Dr. Revati, madam, and all the senior faculties, Aruna and Rajapriya Ippan and Sneha, and all the I mean, a very, very interesting, very academically interested, all from Madhya Pradesh, Dr. Sunita Chauhan, Dr. Sunita Vadwani, Dr. Nidhi Bajaj, and all the other senior people. I thank you one and all for being with us. And it is a real nice discussion we had. And it's lovely to have the beauty of the motherhood to talk in the beautiful way by the senior people like madam and all. And we really enjoyed each and every aspect of this webinar. And I thank one and all. And beyond all these things, I have a special thanks to all the delegates who joined us. And a very special thanks to Sahiti and Shield team for giving us the nice platform. And a special thanks to Priya for coordinating everything. Thank you so much. And we catch up next month again.
All the best.
Thank you.
All
And
the best.
please nominate from your societies for my candidature on the No to Work committee. Thank you. Bye.
Bye.
All the best, ma'am.
All the best.